Thank you very much for having me. Welcome everybody on this lovely Thursday evening. So beautiful outside. I'm impressed that you guys wanted to come and join me for a little bit. So yes, Jim, thank you for that introduction. Again, a little bit more about myself. Again, I have been at Seattle Children's now officially for 6 months. I made it through my first winter, very exciting, from Atlanta. But I have been working with families of children with ASD and challenging behaviors for over a decade now, and really been focused on doing parenting interventions for families. So I'm going to be talking a little bit about what I've learned over the years about the program that I'm particularly involved with, which is actually a new clinical service at Seattle, at the Autism Center, Seattle Children's Autism Center. And then just spend some time talking about challenging behaviors and some kind of how we conceptualize them or think about them, and then a brief introduction to some strategies. So I think I probably just gave you the rundown of this. So again, I'm going to talk about parent training more broadly in ASD. Believe it or not, it's actually a pretty complex and multifaceted type of treatment for families. Talk about the program that I'm involved with, 4 key concepts to help us think about why challenging behaviors are occurring, and then again provide an overview of common strategies. So let's just start back at the beginning here, which is thinking about current prevalence rates. So the latest, oops, I have to say over here, sorry. I like to wander. Apparently I'm not going to be able to wander today. Current prevalence rates of ASD, we're saying are around 1 in 68 children. And if you look at kind of worldwide estimates, they say 6 per 1,000 children. So there's oftentimes this question of why is there this increase in prevalence rates? And I think our best answers currently are that we're broadening what autism means. So 20 years ago, you would oftentimes think of autism as children who maybe were quite impaired. Now we think about ASD in a much broader scope. And when you broaden the scope and broaden what autism means or how it's defined, you're naturally going to end up identifying more children with the condition. Certainly increased public awareness. I think it's, again, something we didn't hear much about 20 years ago, and it's something that is more common in our vernacular these days. And then better diagnostic tools. And so the way that we even identified or diagnosed ASD has changed pretty notably just in the past 20 years. So if we kind of take all these factors together, they can help us to think about why we might be seeing more cases. So there's some good news and bad news with this increased prevalence. One is that we are better at identifying kids with ASD. The challenge is when you identify a child with ASD, then the next logical step is to start thinking about services for that child. And that's where sometimes we're having a little bit of a gap or a little bit of lag in terms of keeping pace. And so at this point, it's a condition where the access to evidence-based treatments can sometimes be challenging for families. So getting access to evidence-based treatments and even just understanding what evidence-based treatments are out there can sometimes be a challenge. And so this is actually a slide I've been updating for about 3 years now. So if you have a parent whose child has recently been diagnosed with ASD, obviously a very common thing to go home and do is Google it, right, and to learn more about it. And so I, 3 years ago, entered a Google search for autism treatment and I got about 9 million hits, 2 years ago, 9 million hits. Last year, it was up to 37 million hits, and then this year is up to 50 million hits. So again, a parent who is trying to understand how to help their child, how to get services, what types of services, they're essentially having to wade through potentially 50 million websites or pieces of information about autism treatment. And so I said, well, then if we want to kind of wrench it up a notch, let's add the term evidence-based autism treatment to our Google search, and we just end up with just under 1 million hits. So we were able to narrow it down a little bit, but still we're talking about a lot of information that our families are having to wade through. So the other challenge in regards to treatments for ASD is a lot of evidence-based treatments are costly, time-intensive, and personnel-intensive. And this has implications for wide-ranging dissemination and implementation of treatments. The way that I'd like to cut to the chase with this one is that I would love it if every child with ASD could get the in-home ABA 15 plus hours a week. But the reality is there's a lack of, a shortage of providers. in relation to the number of kids who need those services. And so while we have a need, the ability to fill that need has been a challenge. And that results in difficulties with families accessing services to treatments. And I have to say, at this point in time, I've now become intimately familiar with service systems for 3 states. So I was originally up in Connecticut for almost a decade, and then I was down in Atlanta, Georgia for 4 years, and now I'm here in Seattle. And I've had colleagues all over the country, and it's not a state-specific problem. This issue of access to service is really kind of a universal challenge that a lot of our families are facing. So for me, I'm certainly thinking there's this need to be able to increase access to empirically supported, time-limited, and cost-effective treatments for ASD. The hope is that we can, give families the services they need, but also potentially find ways that we can meet needs that don't require necessarily the kind of standard or traditional, more intensive types of treatments that are currently available. So this is where parent training comes into play. It's the idea that you can bring your child to a place where they get the services and the clinician does the work with the child, and you can teach the parents the skills that the clinician would be using with the child, and then they can use the skills all day, every day. So there's this real idea of the value of really having parents be active partners in the intervention process for children with ASD. This isn't coming out of nowhere. Parent training as just a form of intervention has been around for many, many years. It has a history of being a time-limited approach. In fact, standard parent training programs tend to be 1 to 2 hours a week for maybe 12 to 14 weeks. So really short-term, time-limited. Again, it emphasizes the role of the parent as the agent of change. So teaching the parent to be the therapist for their child. And just again, to kind of highlight the history of parent training, it's been out there for over 30 years as an evidence-based treatment in child mental health with lots of evidence supporting its efficacy. The focus generally has been on treating disruptive behaviors in typically developing children. And those are some of the programs that again have a lot of evidence to support them. So Kasdan's method of parenting, Sheila Iberg's parent-child interaction therapy, Russell Barkley's Defiant Children, and then Carolyn Webster Stratton's Incredible Years, which I know is here, well entrenched in the community here. So why target parents? Well, first, when we look at children with ASD, there are high rates of disruptive behaviors in this population. When you look at the research, there are estimates upwards of 50% of kids with ASD exhibit some type of challenging behaviors, whether it's noncompliance, aggression, self-injurious behavior, elopement, etc. So this is a problem that our families are very often encountering while raising their children. We also know that kids with ASD oftentimes have adaptive skills deficits. And what that means is that they are not performing on a daily basis what they are capable of performing. And the best way to kind of understand how this looks or how it works in kids with ASD is you have a child who has a certain cognitive functioning level. So whether it's an IQ of 120 or 100 or 70 or 50. The idea is that their adaptive skills would be at a similar level. So a child with an IQ of 100 would have a standard score on their adaptive functioning of 100. A child with an IQ of 70 would have adaptive functioning of 70, and so on and so forth. Well, what we're seeing in kids with ASD, especially some of our higher functioning kids, is there's a split between cognitive functioning and adaptive functioning. So the IQ may be 100, but the adaptive functioning score is a 70 or a 75. Or a child with an IQ of 75 has an adaptive skills score of 55. Again, what that's telling us is they're not living up to their potential. They're not doing day in and day out what they're capable of doing. And on a very practical level, what this means is, for example, I have kids who cognitively and motorically are capable of getting themselves dressed. They know how to get themselves dressed. But day in and day out, they refuse to do so. And because they refuse to do it, usually that means the parent does it for them, and the child essentially doesn't get credit for that as an adaptive skill. Brushing teeth is another example, bathing, appropriate mealtime behaviors, etc. So we see, again, not only this higher rate of disruptive behaviors, we see these challenges in relation to adaptive skills deficits. And those two result in a high degree of parent stress and accommodation. And when we think about parent stress, we're talking about higher rates of stress for parents of children with ASD compared to parents who have children with other developmental disabilities. Developmental disabilities. And then the accommodation piece, again, is that idea that because the child is not doing the skill for themselves, the parent finds workarounds to do it for them. Or they just avoid asking the child to do it altogether. So I very commonly hear my parents say things like, I feel like I'm walking on eggshells. I don't know what's going to set my child off. I avoid things so I don't set him or her off. And so I find that I don't make my child do things that I would really like them to do. And so our families are looking for those tools to help their child really live up to their potential and do all those things that they're absolutely capable of doing. And they just need support to know the strategies to help them in that respect. And then lastly, while it's a common recommendation, a child gets a diagnosis of ASD and they get this lovely long list of treatment recommendations. Somewhere in there should be the highlighting of parent inclusion in treatment. Parents should be a partner in their child's treatment process. And unfortunately, this isn't always the case. And so I hear examples of parents say, you know, I take my child to therapy and I drop them off, and then I sit in the lobby or the waiting room, or I go run errands, and I come back, and maybe I'll have a once a month kind of check-in, but that kind of, there's a feeling of maybe not active inclusion in treatment. And that's important because we know kids with ASD have difficulties with skill generalization. So while skills may be working towards mastery in one setting, it's not always intuitive for the child to then carry those skills over into another setting. And so the idea that bringing parents in more actively as part of the treatment team is important and valuable, because they're the bridge, right? They're the ones that we want to have them to help support their child to be successful in other environments. So that's hopefully enough of a logical reason why I think parents are very important to be a part of the treatment process. So we know our families are looking for instruction or techniques on how to improve core symptoms of autism, how to reduce challenging behaviors, and how to improve adaptive functioning in their children. So this is my sidebar. Sorry, I'm feeling really restricted. I'm so used to wandering and pacing. This is so hopefully I've made a case that parent training is a really great thing for our families. I mean, if I were building systems, I would say every parent should get parent support in helping their child succeed. But there's an interesting question in the context of ASD, which is what exactly is parent training? So again, my original background, way back in the day, was parent training for kids with oppositional defiant disorder and ADHD, so not ASD. And for me, in general child clinical psychology, or in child mental health, parent training means parent training for disruptive behaviors. Like, there's no other variety, right? And I could be in a clinic and say, oh, I'm doing parent training, and everyone would be like, oh, yeah, is it PCIT or is it Incredible Years? But everyone knows what I'm talking about, right? So I went into the world of autism thinking I could carry that label over and people would know exactly what I'm talking about. Except the first time I sat down at a table with clinicians who work with kids with ASD and said, I do parent training, they're like, well, I do too, except I do it for joint attention. Well, and I do too, but I do it for improving language. Well, and I do too, but I do it for feeding. And I realized that parent training really is much more complex and diverse in the context of ASD. And I think this is important to know for our families so they know what they're getting signed up for or what they should be asking for when it comes to treatment. So this this is ultimately how I helped and my colleagues helped to kind of frame what parent training in ASD is. And as you see, it's not a one line to one line. It's actually a very complex and multifaceted area of treatment and support. And the way that my colleagues and I actually started off with this is breaking it down into interventions or programs that were focused more on the parent support side of the spectrum, and then the parent-mediated intervention side, which is more about teaching techniques. So to kind of start on the left-hand side where it says parent support, the focus of these types of programs are really about enhancing parents' knowledge about ASD, and the child ultimately is an indirect beneficiary. So if you as a parent become very savvy about the IEP process, you are going to be a better advocate for your child. But it can be complex, and it can be hard to understand what an IEP and how you navigate and how you support your child. That process can be difficult, and so I think it's important for parents to get that information, and that would fall on this side of the taxonomy. And we actually also break parent support down even farther into care coordination and psychoeducation. So care coordination is a service that involves working with someone to help you navigate the system. So one thing we know very clearly about kids with ASD is they end up navigating multiple healthcare systems. So it's psychiatry and psychology and the BCBAs and medical, they got GI issues and, did I say medication already? We got in neurology, if there's, concerns about seizure activity. So we have multiple systems that our families are having to navigate through. And sometimes it's helpful to have a person or a support in place that helps you understand what your options are, where those services are available, how you can get support and advocacy. And so that's what care coordination is. It's helping families navigate the system. Psychoeducation is what it sounds like. It's just learning more about autism and everything that entails. So that's learning about medical, co-occurring medical issues and treatments available and educational supports and advocacy. But those are all about helping parents become better advocates for their children by learning what they need to know about autism. On the right side is where you actually get into your interventions. Your parent, and the newer term that's coming out is parent-mediated interventions, and I actually like this term better. But parent training, as a label, gets a bad rap as a label, and it's actually not a very good label, because it doesn't really give credence to how much that type of intervention is about partnering with the parent and not just having them come in and tell them what they need to do. So parent-mediated interventions is a better term because it really highlights that it's the parent that's doing the work. It's the parent that is being being empowered to be the therapist for their child. So when you look at parent-mediated interventions in ASD, they're obviously more technique-focused. The child's the direct beneficiary. And for ASD, you can break it down into parent-mediated interventions for core symptoms of autism, so language, socialization, play, etc. And then you have maladaptive behaviors. So those are disruptive behaviors, feeding issues, toileting issues, sleep issues, elopement, those things that aren't required to diagnose ASD, but commonly occur in children who have ASD. And there is a parent training program or a parent-mediated intervention for every single one of those things that I just listed off. So when it comes to you looking for services, one question is are you interested, or is your primary focus at that point more on improving your child's core symptoms? Or is it really about getting the sleep issues under control, or getting the disruptive behaviors down, or feeding issues, very common, getting your child to eat better? So you could have a parent-mediated intervention for any one of those areas. And then the last thing that we actually break it down even farther, because this is how the field has developed, is we have parent-mediated interventions that are considered primary PMIs or complementary PMIs. And a primary PMI is an intervention where the parent is brought in day one, session one, and is from session one the implementer of the intervention through coaching and teaching with the therapist. But really the parent is the one that's implementing the skills. That's compared to complementary programs, which often start with the therapist and child working together, and then the parent is brought in at some point to help promote skill generalization. So some examples that I have of those programs, Connie Castrie's JASPER program is a primary PMI for core symptoms, and so it's where the clinician goes into the home and works with the parents and teaches them the skills to help the parent improve their child's joint attention and social engagement. Whereas the Early Start Denver model, as it was originally developed, is a complementary
PMI for core symptoms, because it really was the therapist working with the child in the home, and then the parent got, I think, twice monthly coaching sessions or educational sessions with the therapist. For the maladaptive behaviors, the primary PMI is the Ruby program, which is what I do. That's what I'll be talking about more about in a moment. And then the complementary PMI for maladaptive behaviors would be the Marcus Autism Center feeding day treatment program. So that's where kids go from 8 a.m. till 4 p.m. all day, 5 days a week, working on their child's very significant and severe feeding issues. And then once the child starts making gains in their feeding, the parent is then brought in to start generalizing what the therapist has been working on with the child to have the parent implement. So, very long-winded way of saying parent training in autism is complex. And for parents out there, know that there are lots of options available and that target various facets or aspects of what you might be wanting to work on. I'm very, very excited to say that the Seattle Children's Autism Center has programs that fit every single one of these boxes. So they have care coordination and psychoeducation. They have parenting programs for core symptoms. They have parenting programs for maladaptive behaviors. So it's very exciting to work in a place that can check every single one of these boxes, which is really cool. As I said, the program that I've been focused on is the Ruby program. It's that far right blue box that's shaded. And I'm going to just go and give you a brief overview of the research on this particular program. And I have the psychoeducation box shaded blue because in the study that we did, we actually did a randomized clinical trial of the Ruby program compared to an autism psychoeducation program. So that's what I want to just do a quick overview of right now. Again, just so you can be familiar with this new program that we have at the Autism Center. So this is a study that was actually published in JAMA back in 2015. So that's a simple way of saying it was a very well-designed study that had some very exciting results that came from it. Essentially what we did is we did a randomized clinical trial of 24 weeks of the Ruby parent training program versus just a general parent education program for kids with autism and co-occurring disruptive behavior problems. Again, the psychoeducation was similar in length and intensity as Ruby, and it worked directly with the parents. It just didn't talk about how to treat disruptive behaviors. It was everything you would want to know about autism except how to treat problem behaviors. This is currently the largest randomized clinical trial of a psychosocial intervention in all of autism. We will be holding that title for just a short while longer. 180 families were randomized to those two treatments. We focused on children ages 3 to 7, although I will say that the Ruby program has been studied in kids up to age 14. Again, the treatment was delivered individually to each caregiver in 60 to 90-minute sessions in the clinic. And this is just a quick graphical representation of essentially what happened. This was our primary outcome measure. The red line is the families that were participating in the parent education program, whereas the blue line was the families that were participating in the parent training program. And the big take home from this is that both groups actually did better. There was actually benefit from just learning more about autism, but that the families that got the parent training program, the Ruby program, did significantly better than our parent education families, and they essentially had a 50% reduction in problem behavior from baseline to endpoint, compared to about 30% for parent education. For those who love stats out there, we had an effect size of 0.62, which was the difference between the two treatments, and that's actually a pretty robust difference. It says there's a pretty robust difference between the two groups at the end of treatment. This is another outcome that we looked at. We essentially had our families meet with a blinded evaluator every 4 weeks to ask, how are things going? Are you getting better? And in order to be a person who was deemed better, they had to be much improved or very much improved. And so this was essentially measuring the rate of families who were considered treatment responders over the course of the 24 weeks. And again, what we see is that families in both groups, or kids in both groups, got better, but ultimately the parent training group did significantly better than the parent education program. I think what was really cool is essentially 70% of the families that participated in the Ruby program were considered much improved or very much improved by week 24. So 2/3 of our families got better, which is a pretty strong outcome for a psychosocial intervention. This is actually one of my favorite slides. Remember I was talking about adaptive skills. The idea that they're typically delayed in children with ASD. And what this slide shows us is that the children whose families were in the parent education program, they were essentially flatlined in relation to their daily living skills from baseline to week 24. But our parent training families, those children showed over 6 points in gains on their standard score of their daily living skills. And essentially what that means is they didn't just keep pace with the passage of time, they actually made more gains than the passage of time, which is how you essentially change a standard score. And so it just is evidence that our quest to improve adaptive skills through our program, we were able to do. So that was another very exciting finding. So it's enough. I'm going to talk about research today. So I want to now kind of dive into the program, the Ruby program, and what we focus on, and what makes it a little bit different from other parenting programs that are out there. So the Ruby program, again, its primary target is to reduce challenging behaviors. So we teach parents those strategies that help reduce noncompliance, tantrums, aggressions, transitions, difficulties with transitions, and kind of going through the daily routine. But we also focus on improving adaptive skills. So this is a hypothesis that our group has been going on with for quite some time. And it's this idea that, adaptive skills deficits are there in part because they connect to core symptoms of autism. So socialization, communication, are facets of what we consider when we're looking at adaptive skills. And so it's not surprising that in a population of kids with ASD that they would have delays or deficits in socialization and communication. But we also see those delays in daily living skills, which again is those things that I've been talking about: getting dressed, bathing, toileting, brushing teeth, etc. And so we've been working under the idea that part of the reason we see these deficits in adaptive skills in kids with ASD is because they refuse to participate in those daily living skills tasks. Again, it's not that they can't do it, it's just that they won't do it. And so if you can get challenging behaviors down and under control, that opens the door to start pushing back into the repertoire and the routine those daily living skills, right? If you get a kid who's tolerant of transitions and demands, you have a kid who's tolerant of being told to brush his teeth and actually complying with it, or staying at the table and complying with that, or putting their shoes on and tying their shoes. And so our program doesn't just stop at getting problem behaviors under control. It stops when the problem behaviors are under control and the adaptive skills have started to improve. So that's really kind of a twofold focus of the program. And again, that slide that I just showed you in relation to the Vineland is essentially the data that we had to support this hypothesis that when you do reduce problem behaviors in this population, it opens the door and allows them to start making those improvements in adaptive skills. Again, there's lots of parenting programs that are already out there. I think what's nice about our program is we made sure to include strategies that we know work really, really well for kids with ASD. So the starting place is the program itself is based upon principles of applied behavior analysis. It's a function-based treatment, which means that we teach parents the antecedent behavior consequence model and how to understand functions of behavior, which I'm actually going to talk about a little bit later today. There's a very heavy emphasis on the use of visual cues and visual strategies. So we know that kids with ASD do a lot better in terms of processing information when it's presented visually versus auditorily. And I know this, and I've seen it happen a million times, but I still am always very pleasantly surprised when I send a family home with a visual schedule and they come back and say, my kid is doing something that I've never been able to get them to do. And the only difference is I showed him what he needs to do instead of told him what he needs to do. So we do, look for every opportunity to add visual supports into what we're teaching the parents to do with the kids. There's also inclusion of what's called functional communication training. It's this idea that, again, I'll talk more about in a moment, which is that behaviors, while problematic, are also very communicative. When a child is having a tantrum, they're trying to tell you something. When they're hitting you, they're trying to tell you something. So functional communication training is about figuring out what they're trying to tell you and then teaching them a much more appropriate way to get their message across, right? And so we include that, knowing that a lot of our kids with ASD have communication difficulties, and knowing that even very verbal kids with ASD have the language go out the window when they're mad and frustrated, right? So kids who are verbal are not immune to problem behaviors. So we want to teach them, no, you have to find different ways to communicate your wants and needs that don't involve hitting, yelling, screaming, pushing, etc. Again, we have this balanced focus on decreasing problem behaviors while also improving adaptive skills. And then knowing that kids with ASD oftentimes have difficulties with skill generalization. We focus on how, it's the last session of the program. So now that we've made some really nice gains, how do we ensure those gains stay around over time? And so we talk about how to promote generalization and maintenance of skills. So this is actually a breakdown of the Ruby program. So if you were a family to participate in this program, this is what you would get. So there's 11 sessions that we want all families to get. It starts with teaching the ABC model and functions of behavior.
What does Ruby stand for?
Oh, great question, and it's a horrible answer. It's the
Okay, never mind.
no, I'll tell you, it's the Research Units in Behavioral Interventions. Yes, yeah. Yeah. It's the Ruby. Just call it Ruby. I've been told multiple times we need to get connected to a marketing group to come up with a better name. So 11 sessions, and again, it follows the ABC model. So we start with antecedent management or prevention strategies, daily schedules. Then we get into consequence-based strategies, so reinforcement, plan ignoring, compliance training. And then the last chunk are those more skill building, functional communication training, teaching skills, and generalization and maintenance. I will say in the research study, we had home visits and telephone boosters. Unfortunately, we are not able to do that as part of our program here. The telephone booster is now just an in-clinic booster. So we still provide that opportunity for follow-up care, but it's just done in person instead of over the phone. The nice thing about the program is it also has a section of optional sessions that you don't have to do, but if they are of concern with your child, we can fold them into the treatment. So as you see, these are more topical issues: toileting issues, feeding issues, sleep issues, timeout, imitation skills, and then contingency contracting, which is just token charts or sticker charts. So there's any number of reasons why we wouldn't use those with any one child, but if it makes sense, we fold it into the mix. And the reality is, to do toileting or feeding or sleep, you need to know how to use visuals and reinforcement and planned ignoring and compliance, etc. So it makes a lot of sense that you kind of teach parents the foundations and then just talk about how you apply them to a particular topical issue. So this is the program that we're currently doing at the Autism Center. So just to kind of give you a little bit about what I think helps to make the program work, it is an active intervention, so it's not just the parents coming in and listening to me drone on for an hour and then going about their business. It's an active teaching session that is designed to help parents think about how they can apply the principles for their child in their home and in the community. And so homework is a very big part of it. We teach the strategies, we think about how they can do it, and then they go home and practice it in the context of their homework. What's nice about the program is the choice of homework comes from standard prompts, and frankly, the standard prompt is, what would you like to work on this week? So very standard. But it's personalized and crafted in partnership between the parent and clinician. And so a big part about this program that I think helps to make it work is that I don't tell you what you're supposed to do. I don't tell you what your homework is. I ask you what you want to work on. And honestly, as a clinician, I might have a brilliant idea that I think would be the perfect strategy, and I might drop lots of Easter egg hints as we're going through the session about how great a certain strategy would be. But ultimately, my goal is to make sure you go home and do it. And so I want you as the parent to be invested in whatever the homework strategy is. So then my job as a clinician is just to help you be as successful as possible in whatever you want to work on. So again, I might be doing reinforcement, and I think, gosh, I just want your kiddo to sit at the table for dinner for more than 5 minutes at a time, and I have a brilliant strategy in my mind, but you really want to work on having your child pick up his toys. So your homework is going to be about picking up toys. It's not going to be about sitting at the table. So you guys, the parents are encouraged to select the homework assignment, the behavioral target, and then the strategy that they want to use. But the program only works if the parents are invested in actually implementing it. And so we really make a big point of making sure parents are going home with strategies and homework assignments that they are excited about and invested in implementing. Which also leads to the personalization of the program. So we shape what the program looks like for any one family based on what the family's need is, the child's age, the child's level of functioning, and what the target behaviors are. So I can say at this point I have delivered and or supervised the Ruby program. I may be working my way to the thousands. And I can't think of any one family that has been exactly like any other family when it comes to how the program ended up evolving, because every family's needs are different. What every child's skills and deficits are different, what the target behaviors are different, and so the program kind of evolved from what any one family is bringing. What I can say, which is really exciting, since we had enough subjects in our randomized clinical trial, we were able to look at moderators to treatment, and that is just, does it work for certain groups better than others? And what we can now say with confidence, because we have the data, is to say that the program works regardless of the child's level of functioning, so it works just as in age, so it works just as well with a nonverbal 3-year-old as it does with a gifted 7-year-old, and everything in between. So it's exciting to think about a program that can kind of have a broader fit for what any one family might be bringing in the door in terms of goals for treatment and family circumstances. Okay, so that's my cell of Ruby. Hope you all are super excited about it. So what I want to switch gears now is just talk more about the heart and the meat of the Ruby program, and I think these are the nuggets that for the families in the audience that you can potentially take home with you. I don't see any of my families in the audience, but if they were here, this would sound very familiar what I'm about to talk about. So 4 key concepts that kind of frame how we work with the Ruby program. The first is we take the point of view that behaviors are learned, that adaptive and maladaptive behaviors are learned. Toilet training is a really simple example. You know, parents do a lot of scaffolding to help teach a child how to use the toilet. There's, timers to tell you how often to go, and then when the child does go, there's a big pee-pee party and singing and stickers, and the child learns, wow, every time I do that thing, then there's a big party, and I'm going to keep doing that thing, and before you know, the child is toilet trained. But it was a behavior that the environment and the individuals in the environment help support the child's learning of that. Waving goodbye is another example. So you might have a baby that you're holding, someone walks out the door, and mommy might wave, and they might prompt the baby to wave, and the baby waves, and the person leaving then smiles and waves back, and then mom gets all excited because the baby's waving, and there's this whole big process going on that is essentially teaching the child that waving is a cool thing to do that I should keep doing when I see someone walking out the door. So we think of behavior challenges also falling in this pattern of or this cycle of also being learned. And so just to kind of give an example of what this might look like, let's start with a child who has been given a command, go clean your room, and the child runs away and screams when they're given this command. And this is an understandable natural response because they've just been told to do something that they are not particularly fond of doing. Parent has a migraine and does not want to hear screaming at this moment, so they're like, forget it. I'll ask you later, or I'll do it myself, but I can't deal with this right now. So the parent removes the demand. So what has happened now is that the child's refusal behavior has just been reinforced. The child has learned that, heck, when I run away and scream, I end up not having to do that thing I'm running away and screaming about. So the next time the parent gives a demand, there's a decent chance that they'll at least give it a try to run away and scream. Now, mom may not have the migraine the next time, but that they're going to at least give it a go, right? So that's an example of the child's learning process. But something interesting is also going on, because the child is not the only one that's learning something in this interaction. What's also happening is the parent is learning that when I just stop bugging my kid, they stop screaming and running away. And I have a migraine, so I don't want to listen to that right now. And so the parent's removal of the demand is reinforced, which then may reinforce them removing the demand the next time their kid screams and runs away when given a demand. So, and this is a pattern that I imagine you could see playing out. It doesn't mean that every single time a kid engages in a problem behavior that parents are responding in a way that inadvertently reinforces, but sometimes it just happens often enough that it gives the child the reason to try it one more time. Again, the parent is not, literally thinking in this moment, I want to teach my child how to have a tantrum, or to run away and scream every time I tell them to do something. They're thinking, I have a migraine and I can't handle this right now. But in the process, it's inadvertently reinforcing the problem behavior. So just one more illustration. This is a very classic example. So we have, stop me if you've heard this one before. This is a very common one. Ben and his mom are at the checkout line at the grocery store. Ben asks his mom for a candy bar, and his mom says no. Ben begins to incessantly repeat his request. Mom repeats no a few times and ignores Ben's request while placing the groceries on the conveyor belt. So here's mom. She's like, I'm going to be firm. Like, I'm not giving in to this whiny, repeated requesting. Getting ready to go home and cook dinner. I don't want him to get filled up on candy. It's not going to happen. So Ben begins screaming, I want a candy bar, and crying. Mom ignores the crying and screaming for about 30 more seconds, but eventually gives Ben the candy bar. So, to be fair to mom, she's probably getting a dirty look from the register lady. And the grandma behind is saying, honey, just give him the candy. And so she is embarrassed and just wants to get out of there. So she gives the candy bar, and that stops, right? So we had the same pattern playing out where the child is engaging in problem behavior, and his problem behavior is reinforced by the mom's response, but mom is also being reinforced because she's no longer having to listen to a tantrum in the middle of the grocery store. So, of course, Ben immediately calms down and patiently holds his candy bar to be scanned and enjoys eating it on the way home. So what has Ben learned? Yes. So, again, not to say that mom is like in the checkout line, like, let me teach my kid how to have a tantrum. What happened is life. Life happened. And as a product of life, there was an inadvertent reinforcement of the problem behavior, which of course means that Ben is much more likely the next time they're at the grocery store to have a tantrum. And what I like to point out to parents also is that he didn't just learn that tantrums work, he also learned that asking nicely doesn't work, right? He asked nicely and mom said no, but when he had a fit, she gave in. So the next time he may not even ask, right? He might just go right. We hear parents say he goes from 0 to 60. There may be a reason why a kid goes to 0 to 60, because 0 doesn't work and 60 works pretty darn quickly. So yes, he may not ask nicely the next time. So we do think of problem behaviors as being learned in some way, shape, or form. The good news with that is if problem behavior can be learned, it also means it can be unlearned, or a new, more appropriate behavior can be learned in its place. Anything can be learned. We can teach something new. I've already kind of highlighted this, that behaviors can be adaptive or maladaptive. So as much as we focus on maladaptive behaviors, the hitting, screaming, and elopement, we also want to think about those adaptive skills that we want to see more of that, again, also can be learned. Getting dressed, putting your seatbelt on, whatever. Already talked about this as well. Behaviors are forms of communication. So a reframe that I try to give parents sometimes in relation to their child's behavior is to try, if possible, when your child is engaging in a problem behavior, to try and step away, take a step back, and really think about, what is my child trying to say through this behavior? Because I can guarantee you he or she is trying to say something, okay? The question is just, what is it? because it's important to know what it is, and we'll talk about why in just a minute. But we think of any behavior, any problem behavior, as being communicative. It's a form of communication. So it's one goal is try to figure out what the child is trying to say. If you think about a child who's nonverbal, they are completely reliant on their behaviors to communicate, good or bad. For kids who are verbal, they sometimes learn that problem behavior is the more effective way to communicate. But they're saying something, so we want to try and figure out what it is. So here we have a little girl who's very unhappy. The question is, what is she trying to say through her frustration and tears and crying? Is she saying, I want a candy bar? Is she crying because she wants a candy bar? Or is she crying because she's doing some work, some homework, and it's really, really hard, and it's too hard, and she needs help, or she needs a break? So that screaming, crying tantrum can mean many things. Our job is to try and figure out what that problem behavior is trying to communicate. Which gets to the last key concept, which is that behaviors serve a function. Their job is to get a need or a want met. So in the world of ABA, we think about breaking functions of behavior down into kind of 4 main areas. We think of problem behaviors occurring because, one, a child might be trying to get out of something, escape or avoid something, get away from an aversive event stimuli. So a very simple example is when they're given a demand, go clean your room, and they engage in problem behavior. That may be their way of trying to get out of or escape the demand of cleaning the room. A tangible function is really about a child doing something to try and get access to something. So a classic that I see an awful lot is, they're on the iPad, and the parent says it's time to get off, and they start screaming and crying. That's their way of trying to get what they want, which is more time on the iPad. Or maybe there's a cookie that's out of reach, and they start screaming and crying at the counter. That's their way of trying to communicate, I'm trying to get what I want, which is that cookie that's out of reach. We have problem behaviors occurring because they're attention seeking. It's their child's way of saying, pay attention to me. And so you could imagine an example where there's siblings, and maybe one sibling is getting a lot of attention from mom or dad, and the other sibling kind of catches on, and so does something that requires the parent to disconnect from one child and start paying attention to the other one that's acting up. So it's about the child trying to get their attention from a caregiver. And then lastly, we see some behaviors that are what we call automatically maintained. And the driving principle behind these types of behaviors is it's not anything that they're getting from the environment. It's something that's happening internally that is either pleasing or maybe even anxiety reducing, but that's something internal that is motivating the behavior to occur. So if we think about behaviors like hand flapping or body rocking or visually stimming on something, rolling a car back and forth and watching the wheels, there's something that is internal to the child that is essentially motivating that behavior to continue. So we have our 4 functions: to get out of things, to get what they want, to get attention, or because they're self-stimulatory. All right. So those 4 functions are important to know about it. And I'll talk a little bit more about this in a minute. They're ultimately what we connect to when we're thinking about what treatment strategies to use. But sometimes it's hard to just know on the surface what the function of a problem behavior is. And so we have to do a little more detective work, and that's where our antecedent behavior consequence, our 3-term contingency, comes into place. So for the parents out there, I would encourage you to have a little fun over the next couple of days to try and use the ABC model to try and get a better sense of what's going on with your kid's behavior. So the ABC model stands for the antecedent, the behavior, and the consequence. So I'm going to start by talking about what an antecedent is. It's essentially the trigger that sets off the behavior. So a really common, actually I guess the next page has common antecedents. Here are examples of common antecedents. Demands. Go get dressed, likely to set off a behavior. No, you can't have that, likely to set off a behavior. You can't have that toy anymore, likely to set off a problem behavior. And then also we can imagine onset of negative stimuli. So when a child's in a place that's maybe too noisy or too crowded, that might set off problem behavior. So an antecedent is really the event that occurs before the behavior that sets off or triggers the problem behavior. Sometimes it's really obvious, like again, telling a child no can be an antecedent. But sometimes it's not as obvious. I oftentimes have families say, we're just minding our own business, and all of a sudden, my child starts screaming or yelling. And that's where it requires to kind of think what's going on in the broader environment that might have set the behavior off. It might be that the TV is on too loud. Like, it's not too loud to us, but maybe it's too loud for the child. Or some other, a smaller event that wouldn't be noticeable more broadly might be what set them off. But ultimately, the antecedent is what sets off the challenging behavior. And the behavior is what the child does. We think of behaviors in very concrete terms. It's something that can be observed. So kind of describing what you might see if you're watching the behavior. Measured or timed. And so just to kind of give an example of the importance of thinking about behaviors in very concrete terms, and I'm talking about the difference between saying, Johnny was really aggressive today versus, Johnny hit me, bit me, scratched me, and threw an object at me. Both are kind of capturing the same thing, but aggressive is kind of a generic term that could mean lots of different things, where if I say hit, every one of you knows what I'm talking about. If I say scratch, every one of you knows what I'm talking about. So we want to make sure when we're talking about behaviors, we're using very specific descriptions of what those behaviors might be. And so here's just kind of examples of that contrast. So we have, the child gets upset when taken to the bathroom. Well, we know, he's not happy, but it's not a very good behavioral description of what's going on. So a better description might be, he hits, cries, flops on the floor when I try to take him to the bathroom. So you see the difference between those two things. They're both indicating going to the bathroom's not fun, but what one does a much better job of describing behaviorally what's occurring. The next one is the child does not sleep well at night. Sounds like things aren't going so well. But really a much more descriptive behavioral description of that would be, he woke up 2 to 3 times per night and cries out for me. And then the last one, he doesn't like food. A better behavioral description of that event might be, pushes the plate away and leaves the table when presented with a new food. And just to drive this point home is an exchange between a mom and a therapist. So we have mom saying, Tom has been disobedient at home. Is he bad during therapy? And the therapist says, Tom's usually good, but sometimes he's stubborn. So we get a sense that they're trying to talk about challenging behaviors, but mom might be thinking disobedient means, saying no when I tell him to do something, whereas the therapist might be thinking, he leaves the table when I'm doing an activity. It's not a very good behavioral description of what's going on. So compare that to, Tom has been hitting me at home. Does he hit you during therapy? Well, no, he hasn't hit me, but he has pulled my hair. So here, the mom and the therapist are on the same page. They both know exactly what the other person is talking about, and they can think about, in very good descriptive behavioral terms, what behaviors they're interested in focusing on. And this is the conversation that I like to have with my family, is I can't treat problem behavior. I can treat hitting. I can't treat he's bad, but I can treat, elopes from in the grocery store parking lot, or pulls his brother's hair or whatever. I can work with more descriptive problem behaviors. So that's our B. We have our antecedent, which sets off the behavior. We have our behavior, which is a good behavioral description of what we're focused on. And then we have the consequence, which is what comes after the behavior. And we like to think that all behaviors have a consequence that can be planned or unplanned, which means that they're expected or unexpected. So if you speed, you know that there's a chance that there's something waiting for you on the other end, right? A ticket. Or if you hit your brother, a planned consequence might be that you end up going to timeout. So we have the ABC model, and we have functions of behavior. And the question is, how do we link these together? And the way that we can link these together is by doing a little bit of data collection and gathering information on what the antecedent to a behavior is and what the consequence to a behavior is, and then use that information to start hypothesizing what the function of the behavior is. So I have a little example. I'm going to show a video, and I want you guys to look in the video for the problem behavior, in thinking about it in very descriptive behavioral terms, what the antecedent to the behavior is, what the consequence is, and then use that information to hypothesize the function of the child's behavior. And then ultimately to think about what the child's learning in the situation.
Can I have a brownie?
Oh, not right now, honey. All right, it's lunchtime.
But why?
Because it's lunchtime. It's not time for brownies.
Open it.
I said it's not time for brownies.
Open it. Open it.
All right, you can have one brownie. That's it now.
So yay, that video cracks me up because she's such a good limit setter, right? Only one. So this would be what my ABC data looks like. So I shouldn't have given you the answer. So what set the behavior off? It's up there. There we go. The behaviors were, so tantrum, again, tantrum can mean lots of things, right? A tantrum could mean dropping to the floor, kicking, screaming. It could mean yelling and biting. It could mean whatever. So we want to make sure we're being nice and descriptive. He stomped his feet. He yelled. He pushed the brownies at her. And then the consequence. Come on, Mr. Browning. Sometimes when parents see this video and I ask what the antecedent was, sometimes they say, well, he wanted the brownie. That was the antecedent. But that's not the antecedent because that's not what ultimately set the problem behavior off. He wanted the brownie, and if mom had given it to him, he wouldn't have had the tantrum, right? It was the actual act of saying no that set off the tantrum. So what was the function of this behavior? Was it to get out of something, to get what he wants, to get attention, or was it a self-stimulatory behavior? Yes, to get what he wants. Yes. And what did he learn? Yes. He learned that problem behavior gets him what he wants. And so, of course, the next time, he wants something and mom's reading a book, that must be a really good time to go for it. He might try the tantrum, the stomping, yelling to get what he wants. Okay. So,
Question though.
Yes.
How do you take that and turn it around? Just that simple enough. What should she have done? What should she have changed?
Okay, I'll get to strategies in a minute. That's a great lead into we first need to know why the behavior is happening. So in that particular case, the child's getting what he wants. So if we think about relearning or learning a new behavior, the first thing we want to teach him is that stomping, yelling, whatever, will not work to get what he wants. And so we might have antecedent management strategies like, we realize after taking some data that he's always asking for a brownie at 4 o'clock, which is an hour before dinner. Maybe I need to give him a snack earlier in the day so he's not hungry at 4 o'clock asking for the brownie. Or maybe I offer choices instead. I say, would you like carrots or an apple? So I'm not giving a brownie, but I'm giving more appropriate choices. So yeah, but the starting place to think about strategies is always going to be about the function of the behavior. And again, because I know this feels like a lot of work and a lot of, annoying stuff to track ABCs and to think about functions of behavior and sit there with your data charts. But it gives you the information that you need in order to know what to do in terms of treatment. And so I want to use this example to kind of highlight the ultimate importance of knowing the function of behavior. So we have two completely different kids here. We have example 1 kid and example 2 kid. And they're both in class, and the teacher has just handed out the class assignment. And kid number 1 turns that classwork assignment into a paper airplane. He starts talking to his neighbors. He's making funny noises. And the teacher's like, you're being disruptive. Get out of here. Go to the principal's office. This is a kid whose behavior is escape maintain. He hates doing classwork. It's really hard for him. He's just been given something that he's struggled with for 3 weeks now. So he is now engaged in this problem behavior, and the teacher has done a beautiful job of feeding into the function of his behavior, which is to get out of classwork. So what's that kid going to do the next time that he gets the assignment? Same old thing. Paper airplanes, talking to neighbors, making just noise. So, and this is actually a really nice example. On the surface, it seems like a really, really good choice in terms of intervention, right? You have a disruptive kid, get him out of the class. But it unfortunately is a mismatch between the function of the child, the function of the child's behavior and the consequence that was chosen. Take the same exact behaviors. Kid number 2, classwork in the paper airplanes, talking to neighbors, making disruptive noise. Teacher sends this kid to the principal. This behavior is maintained by peer attention. He loves being the class clown. He loves everyone's looking at him and stopping their own work to pay attention to him. So the teacher sends this kid to the out of the class. She's done a beautiful job of disconnecting this kid from the function of his behavior, which is to get his peers' attention, right? So here, the point of this whole exercise is to make the point that it's very common to get hyper-focused on the behavior, right? And to just think that a negative consequence works for any problem behavior. You can time out anything. You can privilege remove anything. You can, do whatever. Negative will get rid of negative, and positive will increase positive. And a lot of times it's just not that simple. We can be more effective interventionists if we're mindful of why the behavior is occurring in the first place. Again, knowing that a lot of behavior is communicative. It's asking that question of what are they trying to communicate? How can we change how we respond to be more effective in reducing the problem behavior or encouraging the more appropriate behavior? So, same behavior, identical behavior, 2 completely different functions, which means it will require 2 completely different strategies. Kid number 1 needs something very different from kid number 2. So that's why we make a big deal about knowing the antecedents and consequences of behavior and understanding the function underlying the behavior. Okay, which gets to treatment, finally. So once, again, the program I do, we spend the first session and the first week really just focus on, understanding the ABCs and functions of behavior, having parents go home and collect ABC data, having them come home and come back to session, talk about their ABC data, and use that to start planting some seeds about strategies. As I said, ultimately we want to know what is driving the challenging behaviors that we see, and then we have lots and lots of choices at our fingertips in terms of what we can ultimately do about it. So as I said, the first couple of sessions in my program is all about antecedent management. How can we prevent problem behaviors from happening in the first place? Because there are situations you can do that. Again, the antecedent is the trigger that sets problem behavior off, right? If you can get rid of that antecedent, you get rid of the problem behavior. And so there's a whole slew of things you can do to try and put in place to eliminate the antecedent, which again eliminates the behavior. Some situations are a little trickier and you can't prevent it away, and that's when you then might move into changing the consequences of your behaviors. So I have some antecedent strategies up here. I'm going to go through some examples in just a minute of antecedents. Consequences would be things like, catching the child being good, or having a special playtime. So if you think about a child who's engaging in negative attention-seeking behavior, really nice way to try and turn things around is to do a combination of planned ignoring and catching the child being good, or maybe upping the ante with some special playtime. So if the child is engaging in that negative attention-seeking behavior, you ignore the heck out of it, but every time they're doing the positive opposite of that behavior, then you would point it out. So a child who whines, you ignore the whining, but when they actually ask in an appropriate tone of voice, wow, thank you for asking so nicely. And so, yes, I'd love to help you out. So that's connecting the strategies to the function of the behavior. And guided compliance. So you have a child who has a lot of escape maintain behavior. Maybe you use a reinforcement system for compliance right away. Maybe use guided compliance to ensure the child understands that when a command is given, their job is to follow through immediately. And I will say guided compliance is one of the sessions where it's just as much about the parents breaking habits around allowing escape or delays in compliance as it is the child learning that their job is to comply right away. So we talk about things like, giving that command from 3 rooms away is probably not the best way to promote compliance, right? I'm looking at my daughter. Guilty. Or that, repeating the command 5 times is not the best way to get compliance right away. When you repeat a command 5 times, you're teaching your child that they don't have to comply the first time, right? Because they're going to get 4 more times before they're made to comply. And so it's just as much about parents learning better ways to ensure compliance occurs right away as it is teaching the child that their job is to follow right away. And then again, we talked about functional communication training. So a child who is engaging in escape maintain behavior, for example, because their homework is really, really hard. And every time they sit down at the kitchen table to do their homework, they're engaging in behaviors to try to get out of doing their homework. We might actually do a combination of prevention and FCT. So we might teach the child, we might do small doses. So you only do 5 minutes and then you have a break, 5 minutes to break, or 5 problems in a break, 5 problems in a break. So you break the homework down. Or you teach the child more appropriate ways of communicating that this is hard for me or I need a break. So yeah. But they all kind of connect to the idea of you want to know why the behavior problem is occurring before in order to know what to do about it.
What's the difference between like guided compliance and like transition? So like I have a 2.5-year-old
Mm-hmm.
and he does really well when I give him like okay in 30 seconds
Mm-hmm.
in
Yeah.
10 seconds.
Yeah.
When we lead him up to that, is that different than guided?
Yes. So the question was essentially. Oh, I remembered. Yeah. The question is, you have 2-year-old, and you essentially are using prevention strategies or antecedent management strategies by warning him that an impending transition is happening. Right. So you're using a strategy that's designed to prevent problem behavior from happening by letting him know in advance that a transition is about to occur. And so the fingers are usually crossed that like, if I just let him know, then maybe, that'll work. And a lot of times it actually does. But sometimes it doesn't. So despite your best efforts of using the prevention strategy, using the warning, you then say, okay, now it's time to go wash your hands for dinner. And then if there is a prediction or there is actual noncompliance, then you move into compliance training, which is then getting the child to move forward with the task of washing hands or whatever the next transition is. So does that make sense? Okay.
So then, in that case, guided compliance would be you walking your kid to the bathroom.
Mm-hmm. Yes. The question was guided compliance is walking your child to the room. Yes. Walking. Yes. Okay. So what I want to do. So yeah. And again, the program. I would love to say. Everyone throw out their kids' problem behaviors and I'll solve it in 30 seconds less. That's not. We take 11 sessions to go through this, but it's really about. There's lots of different tools in the toolbox. It's about knowing why the child's behavior is happening and then figuring out what are the best tools to use to address any one particular challenging behavior. And different things need different things. So that's why there's this lovely large toolbox to use. So what I want to do my remaining time is just kind of walk through some antecedent management strategies or prevention strategies that we use in our program that are designed just like giving the warnings. That's a great example. It's a good setup. Thank you. So one example of a prevention strategy is doing things in small doses, recognizing that problem behavior is more likely to occur when a task or an outing is long. So this is I take my child to the restaurant and 2 hours later, I don't know, why are they mad? Well, that's not really fair. But, we know every kid has limits, right? And every kid's limit is different from every other kid, right? So part of it is knowing what our kids' limits are and then trying to work with them. So if we know, for example, a child can't make it through an entire grocery trip without falling apart, but we don't want to avoid grocery stores altogether, which is what I oftentimes hear with my family is why I take him to the grocery store and it's such a nightmare. I just, go while he's in school or whatever. My goal, we talk about avoiding situations or people as a prevention strategy. It works. If you don't take them to the grocery store, you won't have problems. But that's not functional in the long term. I want you to be able to take your kid to the grocery store and to the family gatherings and to church and to the movies, whatever. So sometimes the starting place, especially for parents who are at the point where they're currently just avoiding things altogether, is to kind of dip your foot in the water by doing things in small doses. So again, if you know a 30-minute grocery shopping trip is too much, you don't do a 30-minute shopping trip, but maybe you say, okay, I'm going to go in and get some milk and a box of cereal and some ice cream, and I need you to stay by my side and use an inside voice. And if you can do that, then you can pick out a treat on the way out. And so you've set up expectations about what's going to occur, how long they're going to be, how many items you need to get, and it's a small enough shopping trip that you're setting the child up for success, and you have that opportunity for them to turn around and leave on a positive note. And that first shopping trip, that's 3 items, can turn into the next shopping trip, which is 4 items, then 7 items, and 10 items, and then you kind of make your way up to more successful trips. The way that one of my favorite examples of this, using this strategy with the family, is I had a mom who was bringing her child to like a mommy and me music group kind of thing. And the lesson was, maybe 45 minutes, we'll say. And she said, inevitably they start doing this thing where they march around in a circle, and my child just goes off the deep end and starts screaming and won't stay in the circle, and it's very frustrating. So we talked about, you have a choice. I know you paid for 45 minutes and you want your kid to be there for 45 minutes, and you have a choice to be there for 45 minutes and leave miserable every single time, but you get your 45 minutes, or he can make it up until that point. And so maybe we don't expect him to make it the whole 45 minutes, but we expect a very successful and positive 25-minute trip to the Mommy and Me class. And so she did that moving forward, and it went swimmingly because she was respectful of kind of what his tolerance and his limits were, and she was leaving on a positive note, and it was just reframing the expectation that it doesn't have to be an all or nothing for a lot of things. Sometimes it's just doing it in terms that are realistic for the child. Another great example are things like birthday parties or family gatherings. Like, you don't have to be there for the 8-hour family gathering or the 3-hour birthday party. You can go, and maybe you ask in advance, like, what's kind of the flow of the birthday party? Well, I know singing happy birthday is really, really hard for my kid, or I know him watching other people open presents is really, really hard. So I'm going to arrive before or leave after, or I didn't say that right. But you get the idea. You don't have to go the whole thing, but you can still go and be successful. And it prevents families from getting to the point where they just avoid things altogether. I have so many families that their child doesn't go to the grocery store, they don't go to family gatherings, they don't do birthday parties, they don't do the movies, they don't do all these things because they've had instances where the child has inevitably fallen apart of those things. And that's not the way I want you guys to live your life. I want you guys to be able to bring your kids and be successful. And sometimes getting your foot in the door is the way you can then build up to that full-time birthday party, but or whatever. But small doses. Okay. Changing the order of events. So sometimes kids engage in problem behavior because there are too many demands in a row, or they're having to do something, they're doing something fun, and they're asked to stop doing something fun to do something not so fun. So part of this is just being mindful of what the routine of the day is, and then are there ways to either kind of break up and change the order of events so you have something kind of fun in the mix to motivate completion of less preferred activities, or just having kind of that simple. I'm sure you guys first you do the not so fun, then you do the fun. And I've got lots of families that are using this strategy. In fact, I have 2 right now. One is using it in relation to getting their child to read, and we're both a little surprised that it works so beautifully, but I love being pleasantly surprised. No, so this was a kiddo who the mom wanted him to come home from school and do some reading at some point in the afternoon. And so we talked about what their current schedule was, and he would come home and have a snack, and then he had a lot of downtime before dinner. And so we talked about, well, how about we just say you come home, you get your snack, you have to read 5 pages, and then you can have electronics the rest of the afternoon before dinner. And so that's the very simple kind of first then contingent that we set up. And she came back next week, and she's like, he did it. In fact, he got really excited about it, and she added, because we had this discussion about, well, how do you know if he's really reading the pages, right? And we have fun with this, because there's like, well, do you tell him to read for 5 minutes or 5 pages or whatever? I err on the side of pages over time for homework, because a child could sit there and do nothing for 5 minutes. So I like to say you have to do 2 problems or 5 problems or 5 pages or whatever. And so the mom came up with the idea that he had to pick out 5 words that he liked from what he was reading. And the child spontaneously decided to create, it was shortly after March Madness, a bracket of the words. And he has a little competition going now of like his favorite words that he's picked out. So I don't know. I mean, he took it and ran with it. But it's just an example of like sometimes we underestimate what our kids can tolerate, especially if there's something really motivating for them to do. And so just setting up a simple first, you got to read 5 pages and then you can have your iPad. Or I have a family that's changing the order because the transition was he was doing a fun activity right before he had to start his bedtime routine. And so now we've changed it. So you got to get your jammies on and brush your teeth, and then you can do the fun activity. And then which is the second to last. And the last thing is story time with mom, which is also another enjoyable activity. So the child is getting the worst part of the evening routine out first, followed by 2 more preferred activities, and then that transition away from his highly preferred activity is to another moderately preferred activity. So making that transition easier. Changing how you ask or respond demands sometimes, oftentimes, elicit problem behavior. So the idea behind this, the most common strategies are, as we already talked about, providing warnings or providing choices. So no kid likes to hear no, you can't have that. Providing choices is an option that eliminates your need to say no while also giving the child a sense of control over what they are doing. I have many kids that I work with that part of their problem behavior stems from issues around control and rigidities. I have a group now. I call them my little lawyers. They're great debaters. They're great negotiators. They're you offer 5, they come back with 3. You say 4, they come back with 2.5. It's this fantastic negotiating. I mean, honestly. And so no is a really hard word for them to hear. It usually provokes a negotiation. And so choices is a way to kind of get around saying no while still setting some limits. If you guys have my PowerPoint presentation, it said something like Lucky Charms and some other sugary cereal. I just changed that because I can't believe I had sugar cereal in there. Cereal or oatmeal? Cheerios or oatmeal, not sugar 1 or sugar 2. But it's still offering choices. I have some kiddos where even choices are way too much for them. So the next level is it moves out of prevention, because again, the idea behind prevention strategies is that it eliminates a problem behavior from happening in the first place. But sometimes we move into, would you like cereal or oatmeal? I don't want either. Then I tell parents to say, you make a choice or I choose for you. One time. I don't want to. Okay, well, you're having cereal today. And then putting the cereal down and walking away. And it will 95% of the time provoke problem behavior. But the next time you come back and say, would you like cereal or oatmeal? I don't want either. If you don't choose, I'll choose for you. Cereal. Because they ultimately would rather have some control than none, and they oftentimes will be willing to make a choice when they realize that mom or dad will really follow through and make the choice for them, and then not count, because what happens sometimes is parents will say, well, I do choices, and they make a choice, and then I put something down, and then they really, get very upset, so then I offer a third thing. Once you've offered that third thing, you might as well not offer choices in the first place, right? You've kind of negated your power in terms of your choices in the first place. So choices, and then warnings. Knowing that our kids really don't like abrupt transitions, so it's the idea of giving that 5-minute, 10-minute warning, 10, 5, 3, 1 minute warning that a transition is about to occur, can go a long way. It's not perfect for every kid. Some kids love it. Some kids are reactive. I say if you've set the limit of counting down, when it's ultimately time to make the transition, it's important to then make the transition. One of the mantras you'll hear in therapy with me is, my goal is to put power behind your words, and the best way to put power behind your words is to follow through and be consistent. Lastly, using visual auditory cues. I've already kind of talked about this. It's the idea that kids may not understand what is expected of them when you tell them what to do verbally, but they do much better when they're given a visual cue or an auditory cue, like a timer going off. And it's interesting. I've seen this over and over again where parents talk about, like, our routine is the exact same every single day. He knows. You come home, you have your snack, you do your homework, you go outside, you have dinner, you brush your teeth, blah, blah, blah. Nothing changes. And yet every day my child acts like it's a surprise when I tell him it's time to go brush your teeth. And it's interesting because for a lot of these kids, the second you provide the visual schedule, which lays out exactly what you have just told your child, day in and day out, just seeing it visually can make a huge difference. And one of my favorite examples of one of my current cases is this kiddo where the parents actually never had him brush his teeth in the evening. It had, they had a history of trying it, very challenging, disruptive. They had just eliminated it from their routine because it was so problematic. And so we started the visual schedule, and they're like, talking to each other, like, should we put it in? Should we brush teeth? I don't know. I don't know if it's gonna work. I gave them the picture, and they came back next week and were like, our kid is brushing his teeth, and he didn't even blink. It's a kid who had a history of exposure to visual schedules through school, and a lot of our kids, if they're in a classroom for kids with ASD, they should be very familiar with things like visual schedules and visual cues. So this is a kiddo who I had the good fortune of him already having exposure to visual schedules and kind of knowing how they worked. And what they said is he saw the schedule and went, and then went about the routine. Like, he knew it was his job to follow the schedule, and he has been brushing his teeth ever since. Like, they didn't have a problem at all. So sometimes these things work even better than I think they will. So that is a great example of that. And then time timer is another example. So I've talked a lot in relation to visual cues, the daily schedule, having consistency in the daily schedule, predictability, knowing that changes in routine, transitions between activities can oftentimes elicit problem behavior. So we make a big deal about kind of trying to lay out what the daily schedule is, trying to make it as predictable as possible, knowing that you can never have the perfect schedule all day, every day, 365 days a year. But the closer you can get to routine, the better. And then introducing visual schedules. So these are just some examples of visual schedules. Here's a morning visual schedule that has, put on backpack, circle time, math. This is a school one. Do some math, have a snack, go to the bathroom and reading. This is a different version of one where they have the things that they have to do on the left, and when the child finishes it, they get to move it over to the right. Here's a vertical visual schedule. Again, this is it's another classroom one. What you'll notice with visual schedules is this is 3 different versions. My view of visual schedules is not that it has to be one way or the other. It doesn't have to be vertical or horizontal or Velcro or not. It's whatever makes sense for the family in terms of how they'll practically use it and how it will work best for their child. But the big thing is just laying out in some format the routine of the day. And it can be a morning schedule, evening schedule. It could just be the bathroom routine schedule, whatever is helpful. It's just providing that information in a visual format. There's a lot of words on here. The big thing to pay attention to is we're mindful of the format of a visual schedule for any one child. So we have some kids where they really need to see the objects, an object to know what is going on in terms of the routine. Some kids need photographs, so some parents will go and take pictures of the child doing the different routines, so the visual schedule is of the actual child in their house, laying out the schedule. The most common is an icon schedule, so that's where Boardmaker comes in, or sometimes I just go on Google Images and pull off a great picture from there, but they're kind of cartoon representations of whatever the activities are. And then lastly, for some of our kids, using lists is good enough. I have some of our older kids where it's just on a wipey board, like you get up, brush your teeth, eat your breakfast, get your backpack, go on the bus, and it's just it's a written list of what the routine for that day is. So we're mindful of matching the how the format is set up to what makes the most sense for the child and their abilities and skills. All right, 2 more slides. I'm going to wrap this up. So these are my food for thought take-home message slides. One is just knowing that strategies can take time to work. I love it when I send a family home with a strategy for the week and they come back that next week and it has worked beautifully. And honestly, most of the time, a good week worth of focusing on something can do the trick, but sometimes things take a little bit longer. And the reframe I like to point out to parents is kids are having to relearn a new behavior. And sometimes that just takes time. And so to have patience to know for however long the child's been engaging in that problem behavior, they're having to relearn that there's a new system or a new way that they're expected to behave in place of something they've been using effectively for a while. And in line with that, protesting can be a sign that the strategy is working. And certainly we talk about this with planned ignoring. It's the idea that when you ignore a behavior, it tends to get worse before it gets better. But the fact that it gets worse is a signal that you're doing the right thing, because the child's realizing you're no longer responding to these lower level behaviors. So they're going to try a higher level, and if you're still ignoring, they're going to try a higher level. And that's that feedback to you as the parent that, the fact that you're ignoring them is actually registering with them, and they're trying to up the ante to see where your breaking point is. Your job, of course, is to not break. But I had a parent come in one week and say, well, we had set up this system where it was a child who really had difficulty with homework. So we set out, he had to do X number of pages each day. He had 30 minutes to complete the homework. And if he completed it within 30 minutes, he was able to have his iPad when he was done. And in the meantime, if he protested, which is what he tended to do when he was given homework, the parent was to use planned ignoring. So this is a kind of combination of prevention, reinforcement, and planned ignoring. And the dad came back in. He said, well, the first day was a complete failure. I set the timer, and I told him he wouldn't get his iPad until he did, unless he finished his homework. And then I just ignored him, and he went on for 28 minutes. I mean, he finished his homework, but he yelled the entire time. And so for that dad, that was a failure. And I said, well, what happened the next day? He's like, oh, well, he did it right away. And he's been great ever since. I'm like, I just want to reframe. That wasn't a failure. That was a learning experience on your child's part. He was learning that you were doing things differently, and he was testing. And you did a beautiful job of doing what you were supposed to do. And because you did such a good, tight job of implementing, he learned quickly. And you are reaping the benefits from that point on. So I would just say that, when your child balks at whatever strategy you're doing, it means it's working, believe it or not. Pick one strategy at a time. Parents sometimes try and go home and do planned ignoring and prevention and reinforcement. And it doesn't work because you're overwhelmed. The kid's getting set off every 30 seconds, and then you inevitably give in. So it's usually a one step at a time kind of works. And then just consistency, predictability, and follow-through are the keys to your success. So I say kids work under the slot machine principle of if a behavior worked for them once, they'll keep trying even if it doesn't work for them every time. So working 1 out of 10 times might be enough to maintain a problem behavior. So your job is to wait through all 10 times plus 11 plus 12 and let him or her know that that slot machine is no longer going to pay off. And then I also put my Survivor theme in here. I still watch Survivor. I love that show. And I love the theme, which is outwit, outplay, outlast. So when it comes to implementing strategies, oftentimes that's the mantra and the mentality you have to kind of go into things to know that your child has been doing certain behaviors for a while that have worked for them. You need to send a message that that is not going to work, and that requires sometimes to outwit, outplay, and outlast your kids. On that note, I talked the whole darn 90 minutes.
I can't believe how kind you mean. The red was just hitting the 12.
Ta-da! Thank you very much. I'm happy to stay after for questions if people need to. Yeah.
If we could just ask the sites if they have a question first, and if you guys want to hang out, and Karen's
Okay.
willing to hang.
Sites, do you have
So-
a question?
Any well, I can say it too.
How do we know?
They would just talk. Well, was that me? Does anyone have a question at any of our sites outside of Seattle? And they would just talk. And if not, then we'll take someone here. Anybody have questions in here? We got one over here.
Yes.
All right.
Oh, sorry. Oh, you get the microphone.
I'll start over
That's
here
right.
and I'll bring the microphone.
You'll get a mic in a second.
Oh, well, that's, everyone's got to be able to hear you.
All right. So I think a lot of the things that you presented tonight are concepts that I'm familiar with, antecedent behavior, consequence. So one of the things that's challenging for me as a parent is that I have multiple kids, and understanding these things and applying things seems to work for some of my kids. And then I have a child on the spectrum, and it's just nothing we do works, even though we're sort of applying the same types of strategies to all of our kids. And I'm just wondering if you have any additional insight about why is this so hard? Why, if we teach the behavior and we're giving the consequence and we would expect a kid to learn it after 10 times, he'll take 20 and then relapse after a week for no reason.
Yes.
I have a really hard time understanding why we're not getting through to him, I guess.
That is a really hard question for me to answer.
Thank you.
I mean, what I can say is I can speak to the program that we do. And I can say the way that we teach the concepts works because we've studied it and know that it works specifically with kids with ASD. I think what you're encountering is what we oftentimes hear with our families, which is that things that work for my other kids aren't working or aren't connecting the same way that they are for my child with ASD. And I think that's in part because the things that are causing problem behavior oftentimes have different roots than typically developing kids. So we think about a lot of kind of your traditional attention maintain problem behavior with kids isn't necessarily the most common function for kids with ASD, and then you have compounding the challenges, those rigidities, those needs, that need for sameness, that need for control that is much more pronounced than you see in a lot of kids. And I can say this having worked almost a decade with kind of your traditional kids with challenging behaviors, and then working another decade plus in kids with ASD, that they I would say in many different ways are their challenging behaviors come about for different reasons. And I think that helps to explain sometimes why kind of those standard strategies that you use don't seem to work the same with one versus the other. Now, to say why they're not working with your particular child, I mean, honestly, that's hard to answer without knowing a whole lot more about the specifics of your child. Again, what's, and how for your one child it's different than your other kids. I wish I could give a simple answer. I don't know. Well, I'll try. What's an example of a strategy that you've tried that you feel like hasn't been successful?
Well, one of the things that has frustrated me is he has a hard time with transitions. And so we started out with you need to leave in 5 minutes. So I'm going to ask you to put your shoes on in 3 minutes, and then we're going to leave. And it seemed to help a little bit, and then it evolves into this thing where we end up saying, you're going to be putting your shoes on in 5 minutes, you're going to be putting your shoes on in 3 minutes, you're going to be putting your shoes on now. But now he doesn't listen when we say, I need you to do this thing, because he expects you to say the 3 times repetition before he thinks you're serious. So whereas with my other kids, I might be able to say, we have to leave to catch the bus at this time, so in 5 minutes I'm going to tell you get ready to go, and then we're going to go catch the bus. That's effective.
Yeah.
For him, it's like he kind of manipulates every strategy we have into something that's going to fail in some other
Okay.
dimension.
So are you saying he's become reliant on the scaffolding that you provide him?
It's almost like he twists it into something that is more difficult. It's not even that he becomes reliant on it, it's that it becomes problematic in itself.
Okay.
So none of my kids like to eat
Mhm.
dinner, so they all kind of are sensitive to textures, and
Yeah.
so we say, okay, well, here's food we know you like. This is what's for dinner. You choose what you're gonna eat. There's always something you like. It works fine for one of my kids. She slowly expanded her repertoire of foods that she's willing to eat. Now we're at the point where he just doesn't eat dinner
Mm-hmm.
at
Okay.
all.
Well, my last slide.
I know.
I'm running my program at the center. I
I mean, that's
Yeah.
kind of so for, I understand this is not the appropriate
Yeah.
forum, because I think a lot of what we run into comes down to, I need an expert to look at every single one of these
Yeah.
details. It's not clear to me why that's true for this one
Yeah.
kid and not true in the
Yeah.
general
Yes.
case.
Well, I'm gonna go back and say I can't answer that in the context of this circumstance. I think, what we do see sometimes is the need for clarity. Something I've been finding myself saying a lot with my family as of late is it's all about that line in the sand that you draw, and how crystal clear that line needs to be, and then how important it is to stick to whatever line you've drawn. Because what we do know is kids where control, negotiating, rigidity around rules, it can backfire you in a big way when you flex on what that line is. If it's, to the most infinitesimal degree is what we sometimes see. It's an example. Another version of that is kids. For a lot of kids, you can do something and you kind of stick through and are consistent. 7 out of 10 times, and that's enough for a kid to not test limits because you're consistent most of the time. But I have some kids where it has to be 10 out of 10, because if it's 9 out of 10, the behavior is going to stick around. And that's, I try to make a reframe sometimes that really strong-willed kids, there's parts of that personality and temperament that's going to serve them really well. In a lot of respects, it just can be really hard to parent. So I have openings. I'm seeing families. I'm happy to help you out. It's not, unfortunately, I don't think it's something I can answer or solve in this short time. I apologize. Yeah. Oh, yes.
My question is directly related to this slide. It says your new service at Children's. How do we get in? Do we need a referral? Does it come from primary care? Does it come from the person you're already seeing at the Autism Center? Because I'm ready to go.
Hey, cool. Yeah, I do actually. It's a new. We've been open for 5 months now. I actually have openings. It has to be. It can't be a self-referral, but it can be through your primary care provider or another, either an internal, or external referral from another provider. Yes.
Jennifer Mannheim work at referral. All righty, you guys have a good evening.
Let me just to say my particular program is kids 3 to 10 years of age. So the reason I stop at 10 is because part of what we do is things like physical prompting, guided compliance, and if you have a very aggressive 16 or 17-year-old, I don't want you going home without any support and guidance on using the strategies. We have higher level services at the Autism Center that are focused on providing more directive hands-on support for those more challenging behaviors or those kiddos that need, the parents need more support as they're learning strategies. But 3 to 10, yeah.
Oh, sorry, go on.
Microphone, I forgot. Sorry, we'll get you a microphone.
So what strategy can I employ to talk my child off the ledge when he goes into nuclear meltdown because we won't let him have a dangerous object, i.e. a laser?
Yes. Okay. I think I could actually take a stab at this one. So first and foremost, if this is a problem, I would say use prevention and prevent his access to laser in the first place. That's a starting place. If the thing about any strategy is you're strategizing around predictable problem behaviors. Like if it's a one-time deal, I can't help you because we can't work with a problem that's never happened before or will never happen again. But if every third day he's getting the laser and he's inevitably using it inappropriately, one approach is just doing antecedent management, which is like he's not allowed to have access to it. But your next thing about going nuclear, if taking control of it. If he's got it, taking control of it. And then, believe it or not, I believe very strongly in a good old-fashioned dose of plant ignoring when it comes to a child who gets to that point. Because what I say to parents is, when your child gets nuclear, is there anything you can say to him that will talk him down? Is there anything?
No.
Okay, exactly. So the point is, there's nothing gained by engaging verbally with a child who is gotten to that point. And sometimes it's powerful for the child to see that I'm not going to engage with you. I'm not going to negotiate, talk through, coax out, try and, whatever. I've yet to have a parent say that they have been able to successfully do that. And the reality is because you can't. And so that's where I say to parents, when your child is getting to that place, that's your time to kind of exit stage left and wait for him to calm down. Knowing that there's nothing that you can do at that point. But then I go back with, can we reinforce the problem behavior or reinforce the appropriate behavior and prevent and yada, yada, yada. So it's not just about plant ignoring, I should say, but it's just knowing that when your child gets to that point, there's probably not a whole lot you can say that's going to, turn the green light on that maybe they should calm down. Does that help?
Thank you.
Hello.
Hi.
Well, you mentioned potty party. And I wonder if you could say a few words about the other aspect of your program of encouraging adaptive behaviors.
Yes. Yeah. Hey. Yes. So the third and second to last session is all about how do we teach, how do we introduce those more functional adaptive skills. And the core driving principle around those sessions is the idea that sometimes learning new skills can be hard and frustrating, and also that any one skill tends to have multiple parts or multiple steps, right? Brushing your teeth is not it's a skill that involves, depending on who you ask, 12 to 20 steps, right? And any one of those steps can be hard for a child with ASD to learn. Any child, much less a child with ASD. But when we teach kids stuff, we tend to teach all 20 steps at once, right? And so the idea is actually breaking down a skill into its much smaller parts and only teaching one step at a time, so the child's able to focus on one skill, able to develop mastery around that skill, and then move on to the next skill and then kind of go on that way. It's called, you do task analysis, and then you use chaining to kind of teach principles. So that's essentially what we do. We kind of brainstorm with the parent. What skills is your child not doing now that you would like them to start doing? We do make a distinction between they're not doing it now because they know how but are refusing. That is your prevention, compliance, plan ignoring, etc. Versus this is a skill my child has not completely mastered. They know 80% of it, but there's a part of it's hard, so they don't do it at all. Or they knew most of the steps, but not all of the steps. That's what we focus on in terms of skill building. So adaptive skills, you're right. Again, problems with adaptive skills, deficits in adaptive skills can have multiple roots. One is that it's a noncompliance or defiance. And again, that's what the bulk of our program works on. But then there's those true skill deficits, and that's where the adaptive skill, that's where the teaching skills comes in. Yes?
So is there a theoretical difference between squelching an active behavior like a tantrum versus squelching not doing an active good behavior? You see the difference between if the child's disruptive behavior is refusing to get dressed?
Yeah.
So it's actually refusing to do a behavior.
Yes.
Yeah. Is there a difference in the model, or just theoretically the same thing?
Compared to a child who doesn't know how to get dressed?
No. Compared to a child who is having a tantrum, who's active, so there's an active negative action
Uh-huh.
on the part of the child, or a passive negative action.
Yeah.
Right?
Oh,
See the difference?
yes, I do, and we actually we would call both of those non-compliance. They're different manifestations, but both are examples of a place where a child is expected to do something, and they're using some way, shape, or form to communicate that I don't want to do it. either they're screaming at you saying no, or some kids turn into spaghetti noodles and fall on the floor, or some run out the room, or I mean, you can imagine there's different ways to be non-compliant, but I would say it all falls under the basket of they have been given a demand and expectation and they are choosing not to follow. And then we would deal with that with, again, we could still use prevention, reinforcement, guided compliance, whatever, but yeah. Okay.
One more question.
Okay. Yeah.
I've been teaching for about 10 years now, and I've dealt with a lot of kiddos on the spectrum. And working with the kiddos and then meeting the parents, I used to think, oh, okay, that makes sense after I'd meet the parents. And then my son was diagnosed a year ago on the spectrum disorder. And has there been a link between, so it got me thinking, like, is there a link between parents maybe that display behaviors that are similar and their child has learned those? Or I know there has not been a cause necessarily, but we're always talking about, wow, or do we display the same social behaviors, in the way that we talk to people? And have you noticed working with families that, that quote, the apple doesn't fall far from the tree? I mean, I hate to say that, but do you see that?
Well, I would say that's a great question for Rafe, our genetics expert. I will say I have seen every variation of parents and parenting you could possibly imagine, and I can say with a very high degree of confidence that it's the problem behaviors that parents see are not, it's not like, oh, there's only, one or two types of parents that walk through my door and so I can see where it's coming from. No, that is absolutely not the case. And I think, in fact, more often I hear, what I'm doing works with every other one of my kids except for my child with ASD, and it's not working, and I don't understand why. And so then we work through that. But it's a simple answer in terms of the families that I've worked with. I would say no. The broader genetic question again, I defer. Yes. Yeah.
Thank you.
All right. Well, thank you so much, Karen.
Thank you, everyone.
See you next time.